So now let's talk about sonographic liver patterns. There are basically three patterns in the liver: the normal pattern, the centrilobular pattern, and the fatty fibrotic pattern. We already discussed the normal pattern. Now there's the centrilobular and the fatty fibrotic. If you look at it closely, this one has too many portal vein walls. This one doesn't have any, and let's talk about the reason for that. In the centrilobular pattern, what happens is the liver is edematous, so that the parenchymal cells, the sinusoids, the hepatic cells become edematous, increase in water, drop their echogenicity, okay? And that makes the portal vein wall stand out, giving it a starry night appearance. So you have these bright walls standing out in a dark background of the night sky. So what we see increased brightness and of the portal vein walls, and we seem to have more portal vein walls. Now the liver does not make more portal veins, it's just that we see them because now we have more contrast. This pattern is seen with acute hepatitis, also seen with acute right heart failure. You may see it with infiltrative diseases of leukemia and lymphoma. We used to see it with toxic shock syndrome, but we don't see that much anymore. And we can see it with 2% of normal cases. And the 2% of normals are usually the young, thin adolescents, maybe 15 to 20 years old. They're so easy to scan and see so well that they look abnormal, and that's easy to tell. The patient is healthy, there's no liver function test abnormalities, so those would be normals. Beyond that, we have to be cautious and rule out liver disease. I would like to bring up fulminant hepatic failure because this is something that's very serious but could easily be dismissed or misdiagnosed. You will not see this often, but when you see this, you should think of fulminant acute hepatic failure and liver necrosis. What you'll see is areas, patchy areas of decreased echogenicity with prominent portal vein walls, and areas that look normal. They look echogenic, but they're actually normal areas of liver. You look back at these, this is the starry night pattern reflecting acute edema or necrosis, and these are areas of normal or regenerated liver. So they come in patchy areas. This is a case that we recently had of a 22-year-old man who came in with jaundice, and we saw areas of the liver that had increased portal vein brightness, and we thought that that looked like acute hepatitis, yet other areas of his liver seemed to be normal. He did have jaundice, and he was not that sick. However, his bilirubin was close to 30. He eventually got up to 30 in the hospital. And he became so sick that he ended up with a liver transplant. So what happened in this case? It turned out that he was using herbs, certain herbs for bodybuilding, and apparently developed some kind of toxic effect from these herbs, and developed liver failure and ended up with a liver transplant. I have seen such situations happen. One case was a sulfa drug reaction, a woman who was on sulfa drugs for bladder infection, who came in as an outpatient and had this appearance. So we thought that something was very unusual and wrong. We sent her to the emergency room, and after I followed her up in 3 weeks, I found out that she too went into liver failure and had a liver transplant from sulfa drug reaction. Another patient that I had, that I recall with this pattern, was a 34-year-old woman who was weak, a little bit jaundiced, and I thought also outpatient setting, and I thought, gee, this liver, something's very wrong. I sent her to the emergency room, and on follow-up I found out that within 24 hours she was dead. Autopsy revealed that she went into heart failure. She had lupus myocarditis and lupus hepatitis and develop this acute fulminant failure. So these are unusual cases, nonetheless serious, and we should not dismiss such an appearance. If you're not sure, if it doesn't look like it matches the clinical picture, we should send the patient right away for evaluation. The fatty fibrotic pattern is opposite. We have increased echogenicity of parenchyma. There's some kind of infiltration with fat or fibrosis going on in the liver, which increases the echogenicity high enough that it matches the portal vein walls, and the contrast is lost. Therefore, we do not see the echogenic portal vein walls. In this pattern, we look at the echogenicity, that's increased, but then we have to look now at the echo texture. It could be a smooth, homogeneous echo texture of the parenchyma, or could be heterogeneous or coarse. Sometimes we see sound attenuation, and this type of pattern is usually seen with fatty infiltration, but also seen with chronic hepatitis and cirrhosis. So here's the fatty fibrotic pattern with the homogeneous echo texture. Here's the fatty fibrotic pattern, loss of portal vein walls, with the heterogeneous pattern. Notice we almost see little tiny rounded masses throughout, a little bit nodular. That's what gives it this heterogeneous appearance. Let's look at the fatty liver. Fatty livers are of this pattern, echogenic, loss of portal vein walls. When it's a very pronounced case, there's so much attenuation that we can't even image the hemidiaphragm, as we have in this case. We've tried to increase the TGC curve posteriorly, and we cannot fill in with echoes. Notice how nice and homogeneous this pattern is. Now, fat can do two things focally. We can have focal fatty infiltration, and we can have focal fatty sparing. Okay, here's focal fatty infiltration, where we have areas of fat. Now, the fat part is echogenic. Fat areas of fatty infiltration interdigitating between areas of normal liver parenchyma. And we also can have focal fatty sparing. Here are areas of normal liver, not affected by the fatty infiltration. You look carefully, you see little vessels inside. There's no distortion. This is a completely normal little liver pattern. That's areas of normal liver spared. These can possibly be confused with liver masses. However, they occur in a very typical location around large portal veins, around fissures, and subcapsular. So we tend to look in those regions, and we look for internal architecture and see that it's not distorted. Cirrhosis has this fatty fibrotic pattern. Now, when we make a diagnosis of cirrhosis, we look for heterogeneous echo texture, so coarse sometimes that it looks moth-eaten, and it's from these little islands of regenerated tissue mixed with diseased tissue that causes this heterogeneous pattern. The livers tend to be small and shrunken. They have a nodular surface. Often there's ascites to help us delineate the surface. And these are the livers where we can see the enlarged caudate. So if you see an enlarged caudate to right lobe ratio, and if it's over 0.73, that's a 99% specificity for cirrhosis. It's not sensitive, but it is specific. Here's a cirrhotic liver. Try to imagine what you would see on ultrasound. You see these nodular areas of regeneration all throughout. In between are these fibrotic bands, and that gives this nodular appearance, sometimes micronodular, sometimes the nodules are bigger, and sometimes macronodular appearance. Look at these tiny little islands of regeneration inside the liver, which cause vascular channel disruption, etc. So when we see a cirrhotic liver on ultrasound, we then have to right away look for clues of portal hypertension. So with portal hypertension, the liver is diseased. The liver parenchyma develops resistance to blood flow. This increases the portal venous pressure. Eventually, the portal flow will slow down and it will reverse, and flow will actually be going away from the liver, hepatofugal, and there's then increased risk of bleeding because collateral vessels open up. The ultrasound findings of portal hypertension include ascites, a dilated main portal vein, splenic vein, or spiromesenteric vein. What is a dilated portal vein? Well, a portal vein bigger than 13 millimeters in diameter we consider dilated. A splenic vein or superior mesenteric vein centrally, when it measures more than 10 millimeters, we consider that dilated. So just a simple measurement. We look for collaterals. Splenomegaly is part of it, and various Doppler findings. Where would we look for collaterals? Well, right away, the first place to go is the gastroesophageal junction, GE junction. We then can look for a coronary vein, which would be a little branch off the main portal vein or off of the splenic vein. We would look for a recanalized umbilical vein heading towards the umbilicus. We can have gastrosplenic vessels. We can have a splenorenal collateral. We can have a gastrorenal collateral. We can have perisplenic, all kinds of retroperitoneal collaterals, vessels that we don't usually see suddenly appear. So we try to look for them. On ultrasound, here is the aorta, the gastroesophageal junction, GE junction, and tortuous serpiginous vessels in the region. These would be the gastroesophageal collaterals. Here is a sagittal section through the recanalized umbilical segment, recanalized umbilical vein, and it has flow heading out of the liver towards the umbilicus, hepatofugal flow out of the liver. In this image, we see the splenic vein, which is posterior to the body of the pancreas, and it seems to have a branch. We usually never see a branch there, but when we see such a branch, that's a perfect place for a coronary vein. Here's a spleen with large vessels around it, up in the left upper quadrant. Perhaps these are gastrosplenic collaterals. Here's perigastric or perisplenic kind of collaterals. Here's a large spleen with the left kidney, and there's a large tortuous vessel in between, a splenorenal shunt. What are the Doppler findings in portal hypertension? Well, let's look at the portal veins. First of all, we're going to lose the respiratory variation. The waveform becomes very flattened. We have a drop in the velocity of the main portal vein, and eventually it may reverse and be on the reverse side hepatofugal flow. Hepatic veins. Hepatic veins start to lose their normal pulsatility. We had systole, diastole, kick, systole, diastole, kick, and now all of a sudden it's becoming a very flattened waveform. Hepatic arteries, the only thing we'll see is that they can become quite large. And also notice here on this color image, the hepatic artery is red, the main portal vein is blue. They're opposite colors. The artery and portal vein should be the same color. This means that the artery is going towards the liver and the vein now has hepatofugal flow. So we can see that as two different colors. You can also see enlarged hepatic arteries in the parenchyma of the liver. And what happens in that situation is in the portal triad, where you have the little portal vein, on top of it is dilated a little hepatic artery. Now also sits there the bile duct. Usually when we see a dilated duct on top of the portal vein, we see this parallel channel arrangement. But it can also be seen with a dilated hepatic artery. We turn on Doppler. One has venous flow, one has arterial flow. Now, the last segment that I'd like to talk about the liver is regarding liver masses. Ultrasound is excellent in detecting focal liver lesions. We're very specific. We're specific for liver cysts, but liver cysts that are about 1 centimeter or more, because very tiny ones we may not be so sure about. But ultrasound is not good in differentiating among the different pathologic entities. There are very few ultrasound features outside of cysts that are characteristic of the mass itself, the pathology. We are not good in distinguishing between benign and malignant masses. Triple face liver CT and MRI are excellent modalities for this, but we are good for picking up a focal mass, and we are also very helpful in the diagnosis in the proper clinical setting. We're good for follow-up and as a guidance for biopsy. We can see simple cysts. Now, this is a classical cyst like anywhere else in the body. Anechoic mass, smooth margins, excellent sound transmission. So this is a simple cyst in the liver. What else can be simple cyst? Well, an old hematoma, a hydatid or echinococcal abscess, which this is. This is a patient from Egypt who had a solitary cyst, and eventually this was diagnosed to be echinococcal. A biloma or a seroma can look like a simple cyst. And if we ever have a vascular structure, or if we ever have a cystic structure that looks unusual, not perfectly round, we should always think of the possibility of this being some type of vascular structure like an aneurysm or some unusual fistula like arterial portal venous fistula or portal to hepatic vein type of a fistula. We can have multiple cystic lesions throughout the liver. Very often these are associated with adult polycystic kidney disease or the dominant polycystic kidney disease. We could see multiple cysts with echinococcosis or hydatid disease, as was in this case. We can have multiple cystic lesions throughout the liver that are actually choledochal cysts, the type 4 and the type 5. Type 4 has the dilated bile duct. Type 5 has a normal bile duct. But we can see these cystic structures throughout the liver. If we look at them closely, we will realize that they actually connect, and these are tortuous tubular structures. But many times they just look like collections of cysts. This is a reminder for you of the choledochal cyst. The type 1 has a dilatation of the bile duct. The type 2 has a little diverticulum, a little cyst, off the bile duct. Type 3 has a little choledococele protruding into the duodenum. Type 4 has dilated biliary ducts throughout the liver looking like small cysts, and it also has an associated fusiform dilatation of the common bile duct. And type 5, or Caroli's disease, has the dilated intrahepatic ducts but no dilatation of the common bile duct. So these types you can see, and it's these two that would have dilated cystic type structures in the liver. Complex cystic masses. What about cystic masses with echoes inside of them? Well, that could be from a hemorrhage within a cyst. It could be from infection in a cyst. It could be a hematoma in the liver. It could be an abscess in the liver. Notice that there's sound through transmission, so we know that this is of a cystic nature. In this case, this was an abscess. It could be a biloma or seroma. Could even be a large biliary cystadenoma. Or could be cystic or necrotic degeneration within a metastasis or a malignant tumor. Liver abscesses sometimes cause trouble in diagnosis. A liver abscess, when it has fluid and debris is fairly easy to spot, but when it has bubbles of gas or pockets of gas, that sometimes may shadow out the back wall of the abscess itself and may cause confusion in its appearance. Here's another way that an abscess can confuse us. An abscess completely filled with pus can be echogenic and sometimes look isoechoic with the liver, and it may actually mimic liver and you may not recognize it. But your eye then would catch some effect on a vessel. Perhaps you may catch an edge effect from the curved surface, and you would eventually realize that there is an abscess here within the liver. This is a fairly characteristic appearance. If you saw a cystic mass in the liver and you saw this kind of folding membrane referred to as the lily pad sign, this is the sloughed internal membrane folding in upon itself, very characteristic of an echinococcal cyst. If you see this, you may be the first one to suggest this diagnosis. Patients travel these days to various parts of the world and may bring back a souvenir, an echinococcal cyst, and nobody may think of it until the characteristic sonographic picture is presented. Other complex cystic masses can occur. We can have benign, we can have malignant. This happens to be metastases that are complex cystic lesions. This one is an echinococcal cyst with internal debris. This one, metastases. So we can't really tell, there's nothing specific. So that's why I'd like to make just a list of hypoechoic masses in the liver. Nothing very specific about these. We can have an abscess, we can have an adenoma, focal nodular hyperplasia, a hemangioma, an unusual atypical hemangioma, focal fatty sparing, microabscesses, they can be hypoechoic. It could be a malignant metastasis, hepatocellular carcinoma, or lymphoma. We can't tell. This happened to be a case of focal nodular hyperplasia, this should be hyperplasia, and this was proven by MRI. We see in the literature that focal nodular hyperplasia has a central scar. However, this is not diagnostic. It's fairly characteristic, but it is not diagnostic. And here's why I'd like to show you. Here's a lesion with a central scar, and this was a hepatocellular carcinoma. This was a lesion that seemed to have a central scar, and this ended up to be a giant hemangioma. So you see, even that central scar is not characteristic enough to be 100% diagnostic. We also have lesions in the liver that are homogeneous and hyperechoic, and most of the time they are hemangiomas. Both of these are, but we have to be very careful. There are other lesions that can look exactly like this that are not hemangiomas. Hemangiomas, when they are found incidentally in asymptomatic patients and in a young patient, a patient under 40, well, such a lesion we can call a hemangioma if it's under 3 centimeters. But if the patient is older, beyond 40, or if the patient has any other medical illness, we have to then prove this to be a hemangioma. Let me show you some atypical hemangiomas. This is hemangioma atypical, heterogeneous. This one has some cystic spaces. This one is not totally hyperechoic. This one is hypoechoic and has some sound transmission. All of these are hemangiomas, but they're not typical. Now let's look at something hyperechoic. What's the differential of a hyperechoic lesion in the liver? Well, we all know about hemangioma, but it could possibly be an abscess, it could be an adenoma, could be focal nodular should be hyperplasia. It could be focal fat, could be a hemorrhagic cyst. And it could also be something malignant. Could be a metastasis, could be a hepatocellular carcinoma, could be lymphoma. Not very specific. All of these are unusual, but this one happens to be a thyroid cancer metastasis. So you see, nothing is 100% in the liver. Now, when we talk about multiple solid masses in the liver, the differential diagnosis is metastasis, metastasis, metastasis. But there are other pathologies that can mimic this, that can be just the same. Usually we would say metastasis and we would want to have a history to see what's going on. But it's still, even in this case, not 100%. We can have regenerating nodules in a liver in cirrhosis like this patient had, and this patient has lymphoma, masses within the liver. So even solid metastases are not 100%. Here's another patient with multiple focal hypoechoic masses, and this was multiple atypical hemangiomas. And this one with small hypoechoic masses was microabscesses in an immunocompromised patient. So multiple hypoechoic solid masses is not always metastatic disease. Some metastases are calcified, and we usually think of them as coming from colon cancer, but there is a whole laundry list of other cancers. We can see calcified metastases with ovarian cancer, breast cancer, stomach cancer, pancreas, osteosarcoma, leiomyosarcoma, chondrosarcoma, teratocarcinoma, so certainly not a specific appearance. What's very useful with sonography is that when we're not sure we need a tissue diagnosis, we can just guide a needle straight into the mass and get a biopsy, or provide drainage if it's an abscess, and that's extremely useful. Before I close, I just would like to remind you that when you have a case of liver metastases, you should always think a little further to see, are those metastases causing any complications, such as segmental biliary obstruction. You should double check the vessels. Are the metastases invading vessels? Is there invasion of the portal vein? Is there invasion of hepatic veins? This is a patient who has hepatocellular carcinoma in the left lobe, and tumor has grown into the main portal vein, tumor thrombus. You should look for necrosis, maybe hemorrhage or some kind of superinfection. These are all possible complications of liver metastases. So in conclusion, we have discussed the appearance of the normal liver. We've talked about normal and abnormal Doppler patterns of hepatic vessels. We've covered diffuse liver disease patterns. We've talked about portal hypertension and discussed focal liver metastases. Thank you for your attention.